Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome back to yet another fellowship snippet. So, Maddie, we have 42-year-old male admitted to ICU, day 4 post-induction chemotherapy for acute promyelocytic myeloid leukemia. Now, the patient was initially treated with idarubicin and all trans-retinoic acid or ATRA. He has become progressively more dyspneic in the ward, and the chest X-ray demonstrates a bilateral diffuse pulmonary infiltrates. Initial exam reveals respiratory rate of 40 breaths per minute, sats of 88% on 10-liter via face mask. GCS is still 14, E4, V4, M6. Temperature is 38.9, heart rate of 144, blood pressure of 95 over 50 millimeters of mercury. The investigation-wise, the full blood count on admission shows hemoglobin of 88, white cell count of 26, and the platelets of 22, with obvious blast visible on the peripheral smear. Also, on coagulation parameters, INR is 3.2. So, what are your differential diagnoses for this presentation?
So there are multiple potential causes for this gentleman's respiratory failure, both infective, of which there are many possibilities given his immunosuppressed state, and non-infective causes. In terms of infective, these can be bacterial, viral, fungal, or parasitic. So bacterial such as pneumonia, community-acquired or hospital-acquired, Pseudomonas, sepsis from another source with ARDS, an MRO, I think he'd be high risk given his immunosuppression, or atypical causes or mycobacterium. From a viral point of view, potential causes include CMV, influenza, HSV or EBV, or some of the other respiratory viruses. Fungal, for example, candidemia, which would be the most likely fungal infection in this time frame, but other possibilities include PJP, aspergillosis or cryptococcus. And parasitic causes are more rare, but potentials including toxoplasmosis or strongyloides. From a non-infective potential, there are multiple possibilities, including a drug-related reaction, such as differentiation syndrome in the context of ATRA, chemotherapy pneumonitis, or a transfusion-related acute lung injury, or it could be a cardiovascular cause, such as cardiac failure, as he might have cardiomyopathy secondary to induction chemo, or a diffuse alveolar hemorrhage or pulmonary hemorrhage. Autoimmune causes such as TTP, neoplasm, like a secondary to the lymphoma itself, or aspiration or other non-infective potential causes for his deterioration.
Great. So what are the management priorities for this patient?
So I'd broadly divide this into assessment and specific management of the underlying cause of deterioration, which initially would be also to empirically treat for infection, the management of his respiratory failure, the assessment and management of shock, and the management of coagulopathy, as well as then supportive management. So in terms of specific management of the underlying cause of deterioration, it requires an assessment of history, exam and investigations, which would be particularly important to assess for infection in this immunosuppressed patient. And I think it has to be assumed that it's infective to begin with. So I'd be treating with broad spectrum antibiotics, Tazocin and Vanc and Gent, and which would adjust depending on his allergies, MROs, risk, fungal infection and presence of devices, and make sure the patient is or has been on fungal or viral prophylaxis. And I'd be giving steroids if it's thought to be a differentiation syndrome. In terms of the management of respiratory failure, I'd commence NIV with brakes onto high flow nasal prongs, aiming for SATs of greater than 92%, but having a low threshold for intubation if there's no improvement, and ensure that this is a humidified circuit if he does get intubated. From an assessment and management of his shock point of view, he'd need full cardiorespiratory monitoring and insertion of lines, including an arterial and central line with platelet cover. And it might need to be a femoral line initially if the patient cannot lie flat due to his respiratory status. Depending on the findings of my initial assessment of his fluid balance and shock state, I'd try a small bolus of 250 mils of fluid, depending on my initial assessment, and see if he's fluid responsive. But I'd start early vasopressors, aiming for a MAP of greater than 65. It is likely septic shock, but the shock can be multifactorial due to other causes such as hemorrhage in the context of his coagulopathic state requiring transfusion, or cardiogenic in context of the chemotherapy with a cardiomyopathy requiring inotropes. So further treatment, specific treatment of the shock would depend on my assessment. And I'd be giving him steroids if he had high vasopressor requirements and he's not already on steroids. In terms of the management of his coagulopathy, the APML is characterized by a high risk of hemorrhage due to DIC and fibrinolysis. So I'd be having parameters of aiming a hemoglobin greater than 70, platelets of greater than 30, and a fibrinogen greater than 1.5, and transfusing accordingly. And I'd be giving him vitamin K and FFP to correct his INR, aiming an INR less than 1.5. And I'd be evaluating for bleeding, especially intracranial and pulmonary, as these are more likely in APML. And so I'd be doing a CT brain if his GCS worsens. It's currently is 14, but if it does worsen or he does have focal neurological deficits. And I would also, in terms of his coagulopathy, liaise with hematology regarding ongoing therapy and prognosis. From a supportive management perspective, he would require a positive pressure room if he's neutropenic, cytotoxic precautions for all staff as he's had recent chemotherapy, and keep him nil by mouth initially while assessing his respiratory function and need for intubation, followed by ideally enteral nutrition and a PPI, and then family update about the critical nature of his multi-organ impairment and ongoing progress in ICU.
Thanks, Maddie. So one of the thing in this patient's differential to consider is differentiation syndrome. So what is differentiation syndrome? What are the clinical features and what is the specific management for it?
So differentiation syndrome is a life-threatening complication of treatment of APML with arsenic trioxide and or ATRA. So it's a systemic inflammatory response syndrome, which is thought to be caused by the release of cytokines from differentiating blast cells and pro-inflammatory cytokines. In terms of the clinical features, so you can divide this into historical features, examination features, and investigative features. So from a history point of view, it occurs most frequently in the first 7 to 10 days of treatment, but it can occur at any time during therapy. Risk factors include leukocytosis and any kidney injury, so creatinine of greater than 125, micromoles a litre, if they're male, if they've got a BMI of greater than 30, or if the APML is a microgranular Fab subtype. Symptoms are pretty non-specific, so they include things like dyspnea, myalgia, and headache. From an examination point of view, it's also pretty non-specific, so patients often have fever, hypoxia, hypotension, and some weight gain, with peripheral edema, pleural effusion, and pericardial effusions can be seen on examination. From an investigation point of view, they have leukocytosis on their full blood count. The chest X-ray might show pulmonary infiltrates, and the UEC and LFT can show renal and or hepatic failure. So as you can see, it's quite a non-specific presentation, but needs to be considered in the right historical context. From a specific management point of view, patients are often on prophylactic corticosteroids with the aim to reduce the risk of differentiation syndrome, even though there's not strong evidence for prophylactic steroids. Treatment involves changing these prophylactic steroids to high-dose intravenous steroids, generally dexamethasone 10 milligrams BD. And the key is really early recognition and treatment with a high index of suspicion required, and treatment started initially while the assessment is still ongoing. And we also need to liaise with our hematology colleagues regarding the dosing of ATRA. So if the signs are severe, the dose is usually decreased or discontinued until the patient improves from a differentiation point of view.
Thanks, Maddie. So another key thing in this patient's investigation, if you notice, there is increased INR along with thrombocytopenia. So what are the potential causes for these abnormalities in this patient?
So other potential causes that might have a raised INR and thrombocytopenia include disseminated intravascular coagulopathy, which can be due to multiple other causes, acute liver failure, massive hemorrhage with or dilutional coagulopathy, a sepsis-associated coagulopathy, depending on the presentation, a snake bite, hits after warfarin or argatroban is given can also have this picture, HLH, or a paracetamol overdose.
And how do you diagnose acute DIC?
So it needs to be in the right clinical context. Have like historical features or triggers that we know cause DIC. So things like sepsis or major trauma or some of the pregnancy-related causes like amniotic fluid embolism. In terms of the investigative findings specifically, there's on the coagulation studies a prolonged PT and APTT, a low fibrinogen, a raised D dimer, and thrombocytopenia on the full blood count. There is a score. So there's something called the International Society for Thrombosis and Hemostasis DIC score, or the ISTH criteria, which uses these 4 parameters, so prolonged PT and APTT, low fibrinogen, raised D dimer, and thrombocytopenia, to give patients with a clinical disorder known to cause DIC a score from 0 to 8, and a score of 5 or more is consistent with DIC.
Thanks, Maddie. So that's the end of our today's snippet. We'll be back with another snippet soon. Till then, goodbye and have a nice time.
Thanks for listening, and see you next time.